Welcome to Humans of Clinical Academia, a Manchester Catalys podcast. This series is all about opening up the world of research, especially for nurses, midwives, and allied health professionals who might be curious about research but aren't quite sure where to start. Because the reality is, clinical academia can often feel hidden, complex, or even out of reach, but it shouldn't be. Through these conversations, we're sharing real stories from people who have built careers in research, the honest journeys, the challenges, and the moments that shape them, to show that there isn't just one path into academia and that it is possible. Today, I'm joined by Professor Dawn Edge, a physiotherapist and Professor of Mental Health and Inclusivity at the University of Manchester. Dawn's work focuses on mental health, equity, and improving outcomes for underserved communities, and her career spans both clinical practice and academia. Dawn, it is brilliant to have you with us today. So let me start with a big one. You've spent your career challenging inequalities in mental health research, but was there ever a point when the work felt too much, or whether you questioned whether change was even possible?
Yes, the short answer to that is always, all the time. But yes, to be serious, one of the things that I find fascinating is that the NHS and the welfare state more generally was set up to eradicate health inequities. So it's odd, isn't it, that 20 odd years on, well, into the 21st century, we're still talking about it. And it wasn't really, I think, for most people until we were in the pandemic and people were realizing that Black and brown and poor people were dying at disproportionate rates, that people started to go, oh, health inequalities, where some of us have been talking about this for decades and really not being listened to and not getting the support, the funding and such and so on to be able to do that work. So there have been times when it's felt impossible, but never any point at which I thought I should give up. And I think, starting off with something that people are not talking about, not thinking about, like specifically around mental health in racialized and marginalized communities is often a thing. Lots of people have stigma around mental health. It's not peculiar to any particular community, but there are particular issues in some communities that makes that much more difficult. And it's not helped by the fact that when people come into services, their experiences are often so poor that message gets out back into the community. So families then become quite protective, and it can become self-reinforcing, self-fulfilling prophecy that people end up coming into services late, often with much more serious symptoms and worse outcomes. And that's not just for mental health. It goes for physical health. I'm sure you've seen the stats around Black men and prostate cancer, for example, and they are shocking and have been for decades.
So, Dawn, you originally trained as a physiotherapist. Can you take us back to that time? What got you into physiotherapy in the first place?
So, I've always been active. And so I remember speaking to my, what they call careers counsellor at school and looking at what the options were for me. And I liked science and study, and I was good at sport. I was a school games captain, and I think there was in her mind anyway, oh, well, physios do sport. And I think that's for a lot of people, especially back then. I don't think I'd ever seen a physio other than the person running onto the football pitch. I'm a Manchester United fan, by the way. Anyway, so I'd never seen physio in any other context than somebody doing physical things with sport. So I was like, oh, that sounds good. Yeah, so that was the start of my journey. I didn't know any other physios. And for the longest time, and this is a recurring theme in my career, I was the only person I knew as a physio that looked like me. It's not the case anymore, but it was for the longest time.
Wow. How did you experience that? Was it a surprise to you when you realised that there was no one else on your course?
No, because that's been my journey with pretty much everything else in my life since. So background to this is that I came to the UK from Jamaica. I was 11 when I arrived in the UK. So it's not been uncommon that I've been the only person that looks like me in an entire village, or let alone a course, so it's, that wasn't surprising really. And it's good to see that that's changed and there's much, much more diversity in physiotherapy now than there was.
And back then, was research even on your radar?
No, so we knew about research. We were taught research. We had research modules. We had introductions to research. But there wasn't any sense in which it was something that we could do. And then actually I went on a placement to Wythenshawe Hospital as a student and met physios who were doing research, cystic fibrosis, and really cutting edge research. I was like, oh. But I still didn't think it was something that I did. I thought them because these were brilliant, brilliant people, very senior. I was a student. So I just thought there was some kind of magic that happened that enabled some people to morph into these careers, but that maybe didn't occur to me that it would be for me.
At what point did your focus or your interest shift from physical health, as a physiotherapist, to mental health and the type of research you do now?
At the point at which I decided I wanted to do a PhD, well, I say I wanted to, I realised that I needed to. So I'd transitioned from having a purely a career as a physio into higher education. So I was a lecturer. And then realised that most of the people who were progressing, or in order to progress, having a first degree wasn't going to be enough. And I knew quite a lot of physios who'd done masters and a few who'd done PhDs. But the more I thought about what a PhD could be for, the less I wanted it to be a big book that sat on a shelf. I really wanted it to be something that made a difference. And that's a strange thing, really, at the time, to think about how that then transitioned into mental health, because that wasn't on my radar. Except I then met somebody who had really serious postnatal depression, really, really serious, to the point where she was actually admitted to a mother and baby unit. I didn't know that such a thing existed. I didn't know that people could have postnatal depression that was so bad that you ended up in hospital. Didn't know that was a thing. But what it made me begin to think about was, how is it that I didn't know any Black women who ever talked about postnatal depression, ever? I'd never heard anybody talk about it. But there were lots of conversations amongst my white extended family and friends when I told them what I was thinking about doing. There was always a story about, remember being as a child and having to go and stay with auntie because mum wasn't very well after having the baby brother or whatever. And for Black women, it was usually, oh, that sounds great. Good luck. And that just made me even more curious. So that turned into my PhD, which at one point was going to be around Parkinson's disease. That's what I thought about doing. And then these conversations made me think, no, actually, there's a need here. There's something here. Other people could do stuff around Parkinson's or strokes or whatever. But maybe it needs to be somebody like me who does this kind of work.
I mean, that's such a massive shift.
Yeah.
I've made some much smaller, thinking about it, shifts in my career, and I found those challenging. How did you find, I suppose I've got so many questions about this. How did you feel about making that shift at the time?
I don't think at the time I thought it was a shift at all. And I don't know what I thought would happen after I did the PhD. I just knew I wanted to do some work that would uncover this hidden stuff that was going on for people who were below the radar, falling between the cracks, whatever metaphors we're going to use, and whose health needs were not being met. That was really the essence of it. And looking at the injustice of being in a supposedly equitable health service that didn't provide care equitably and didn't seem to be curious about why there were some people who were not using their services, who were not being diagnosed with certain conditions. And I just thought that was unacceptable. So it was very much a social justice perspective. And, the 3-year-old in me that's going, but that's just not fair. It's not right. I wanted to do something different.
What were the reactions of others? Because you said that you had some sort of physiotherapy research role models, but they're doing cystic fibrosis. And you come and want to do something that is typically not closely related to physio, although I know there are a lot of physios who do excellent mental health work. How did other people respond when you sort of outlined your plans?
The usual thing that I've had all my life is, why do you want to do that? Oh, you can't do that. But yeah, generally speaking, it's telling me why it's impossible. That was the usual response. And so I found people with whom I could have a conversation about what I wanted to do, who told me that it was not that it was going to be easy, but it wasn't impossible. Yeah, and the first of those, I just have to give her a shout out as my former line manager physio, Jackie Melia, who said, "Oh, I don't know, but I know somebody you can go and talk to." And that turned out to be an amazing woman called Jenny Popey, who's still doing research. And we had this conversation, and she said, "Well, go away and write me a 2-page summary of what you want to do and why you think it's worth doing. And then we'll see." And that was it. That was the start of my journey to moving that 2-page summary into a proposal to get a fellowship. And that brought me out of being a physio lecturer to go and do first of all, a master's, because I didn't have a master's, and then a PhD. And because I was really quite naive, and I've been used to being told that things were impossible, I just thought, I'll just do a master's in my first year and then I'll do a PhD for the rest of the time, which I absolutely do. No sense of how much work that was going to be. Unfortunately for me, I had Jenny and other great people who were there and said, "Right, go for it." And my cheerleaders as well as my guides.
I speak to a lot of clinicians who are thinking about setting out in research, and sometimes they do want to do research into things which are a little bit distant from their qualification or their profession. What advice would you want to give a clinician who is currently in practice, who has this idea for research, but feels like it is outside of their current scope of practice?
In some ways, I guess what I did, knowingly or unknowingly, which is to find your tribe, find people who will support you. And I've had some amazing people who have done that for me. So at the point at which I was looking for supervisors, I met an amazing guy at Salford, actually, where I did my MRes, and wanted him to be one of my co-supervisors. And he said, "No." He said, the work that you want to do, he said, there are elements of it that I can support you with, but there are lots of things that I don't know enough about. And having people who have sufficient integrity, I've never forgotten him, because, he could have taken it on. But he said, "No, I don't think I'm the right person, but I know somebody who I think would be willing to help and would be very good." So I've been very blessed that along my journey, I've found people who have, I guess we didn't call them that at the time, sponsors or advocates, people who kind of opened doors and introduced me to people. Somebody introduced me to psychiatrists at the mother and baby unit, and one of them became an advisor on the project. So I've been very, very blessed that people have been willing to give me their time and their expertise and, to share the journey.
Is there anything that you think you did or you would recommend other people to do when making those sorts of approaches that are likely to get a better response?
I think first and foremost is just being honest about what you want to do and what you don't know. And you might not even know how they can help, but I think humility goes a long way, to be honest. I think you have to be careful it doesn't tip too far, where you don't ask anybody for anything. But I think there is something about approaching people with curiosity, with humility and respect. All those old-fashioned values that your mum taught you when you were growing up. And when people see that you've got a passion for something, if it aligns with their passion and their vision, it might not even be their area of work, I think generally people really want to help. That's been my experience. I have not had people say no, and not as generously as that man did, but for other reasons. But generally speaking, I found people have been willing to help if they can. And when they can't, I've been willing to find somebody else who can.
Mm. So you moved from being a physiotherapist in clinical practice to being a physiotherapy lecturer, and then you developed the research from there. Were there any moments where you felt like you didn't really fit in that sort of academic world?
Yes. And actually, one of the times when I felt it most wasn't doing the PhD and doing the work, which I absolutely loved. I can't tell you, it's the best time of my life. I loved being a physio, absolutely. But the time when I felt that most was when I was coming towards the end of my PhD and thinking what was going to come next. So I'd meet with, because I said my fellowship brought me out of my lectureship role, so that then essentially I was going back into being a lecturer. So then having conversations with heads of school and deans of faculty and saying, I've done a PhD, which is around maternal mental health, so that encompasses midwifery and social work and a whole range of different professions which are within our faculty. I don't necessarily need to go back and do physiotherapy lecturing. There's a lot that I can bring to the faculty. And the response was always, but you're a physio. But you're a physio. And I'm going, yes, but da-da-da-da-da. And it was, but you're a physio. And they just couldn't see it, which is why I ended up having to leave to come to Manchester.
Wow. So it was that sort of being pigeonholed according to your profession rather than your academic knowledge. How do you think they might have responded if you had no clinical background, but they just knew about your research, your PhD and all of that?
That's a great question, because I think they could have seen it then. I think what happened was the pigeonholing, that they didn't see what I had to bring, even though I put it on paper, even though I met with people and had the conversation. They couldn't get beyond the label.
Mm. Mm. What advice would you give to others who are maybe going through those sorts of rejections where it's not a rejection because, it's a grant failure, you're being told something's not good enough. It's a rejection because you see something that other people do not yet see.
Mm. It's hard being a visionary, being a trailblazer, being the first in anything. And again, I guess going back to what we said earlier on, this is where you need to find your tribe. You need to find people who you can go and have honest conversations with. So one of those people for me was the former head of what was then the School of Nursing, Midwifery and Social Work, Karen Luca. And I went and had a conversation with her because coincidentally we were on the board of trustees. So we were both non-executive directors of a mental health trust. And I was in this place of thinking, what the heck am I going to do? And so I said to her, would you mind if I came and had a chat with you? I have no idea how to move from where I am now to the next step. And she was, somebody who was willing to give me her time. And she was not a physio. So I ended up actually having a job in the School of Nursing, Midwifery and Social Work sometime later on. But I don't know that I would necessarily have considered that, although given the conversations I had previously back at my other place, it was a perfect match, wasn't it? And then I went from there and got a faculty fellowship, and that really started to move my research forward. But still, there are people who are like, I don't know why. I don't think this is not the kind of work that we want to do, because it was seen as being too niche. Black women, small number of people, mental health. We don't really have stories about Black women and mental health. It's big, scary Black men and psychosis. That's what the research is about. It's not about sad Black women. So, trying to get funding. So I got very used to the rejections. Until one day I did hear myself say out loud to somebody, well, of course, if I really wanted to get on, I'd be doing research into schizophrenia. And I was like, oh my God. So it's a segue from doing a PhD in perinatal mental health to doing not just psychosis and schizophrenia, but other stuff around dementia, because talking to people who'd been affected and people in my community about what was needed. And people said, we just need everything, really. We don't have support that is culturally appropriate. So we need people who understand that we have different ways sometimes of explaining phenomena, which some people might see as symptoms of mental illness. And if those things aren't taken into consideration, then the remedies for what we see as being appropriate interventions, they will always misalign. And and then what ends up happening is that sometimes the things that we think are remedies, like faith, end up being pathologized. So they become part of the problem rather than part of the solution. So it really needs people like us to be kind of on the inside and helping other people to see that there's more than one way and one size doesn't fit all.
That's fascinating. So for you, sort of reaching academic success was about holding on to the things that were most important in terms of your interests and what you wanted to change, but making a slight shift into a specific focus that was going to be more fundable.
Yes.
Oh, that's amazing. Okay, so Professor Dawn Edge, you are the University of Manchester's first Black woman professor. I mean, you've shared with us some of your journey already, but how was it for you reaching that point, I suppose, reaching the top of the academic tree?
Well, first of all, I didn't know I was going to be the first Black woman professor. I had a feeling I might be the first Caribbean. And you probably know that Manchester had the first ever Black professor in the UK, Professor Sir Arthur Lewis. But like I say, I'm quite used to being first. It's been part of my journey. And I don't think along the way I really thought about success being reaching the pinnacle and having the title. It was much more about creating a space where we can actually acknowledge the disparities that existed and begin to work collaboratively with people with lived experience, with community members, as well as academics and clinicians to do something about it. Because one of my soapbox issues is that we still have such a big gap between research and clinical practice. So we do shed loads of research in this country, but actually the practice so often lags behind. Not in some areas, in some things like cancer care and other things, it's much more, they're much closer. But you look at mental health, and if you went on to an inpatient psychiatric unit now, you probably would see practices that were not that different to 20 years ago, 30 years ago. But we've done loads of research since then about trauma-informed care, about why women need different approaches, about why people from ethnic minority backgrounds need to have their culture taken into consideration. But somehow that gap between what we know and what we do still exists. But we're practicing evidence-based medicine and evidence practice. Like, really? Yeah.
What are things that you think could be changed that would improve that translation of research knowledge into practice?
I think we need to get the two main groups of people that are missing are clinicians from a wide range of background, and not just clinicians, but also healthcare staff more generally, including people in social care, and the patient and their families, because often they're just silenced. They're not seen as being part of a solution. They're the problem. We've got to fix them. But people with, 40 years of experience of sickle cell anemia not having appropriate care, or somebody living with breast cancer, and you're a Black woman, and all the wigs don't fit your hair, and the prostheses don't fit your skin. Do you know, there are lots of things that if you work with the patients and their families could really, really shift the dial. And the clinicians, people at the cutting edge, right there on the shop floor.
So Dawn, have you faced any barriers in your career related to your background or your identity?
So both. So in terms of my background, I think I've already mentioned, when people say wanting to pigeonhole you, so don't want you to just kind of stay in your lane, kind of know your place, know who you are, and stay there. And that also is not just about the professional stuff, it's also being a woman, and being a Black woman is kind of who do you think you are thing. So the other issue for me is about how, when you start to explore your own identity and what makes you tick, and what, as Karen Luker famously said to me once, what gives you fire in your belly? Because this is a long journey, and the thing that is going to keep you going is knowing that what you're doing is worthwhile. So one of the things I haven't talked about actually is my faith, because it doesn't automatically come up, but how the confluence of my faith and some of the things that we've been talking about really has been at the forefront of some of the work that I've done. So you probably know that my parents are what we call the Windrush generation, And when they came to the UK, they were often told to go to another church, so there may be C of E back in Barbados or wherever else, or whatever background. And then, they turn up at church and they would be told that this was not a place for them to worship. So that gave rise to what is called the Black majority church. So people literally got together and started sometimes in their front rooms, and then did fundraising to rent buildings. And then I think it's quite ironic that a lot of them ended up buying the church buildings that had been left derelict by the turning away, UK becoming more secular. So the C of E churches, like my church isn't one of those, ended up buying these buildings, and they're now what are called Black majority churches. They've always been places not just of worship, but places of activism, places where social justice is a real feature, and a sense that faith isn't something that you do in church, but it's something that you live every day. And so what are you doing with it? What are you actually doing with these gifts and these tools that you have? So when I started to think about what kind of research do we need to do to address some of these inequities, it just seemed self-evident that we'd have conversations in church. So we started having community conferences about faith and mental health. And what was so wonderful, the first one that we did, we had over 500 delegates over a weekend. But there were Sikh, there were Muslim, there were Jewish people, there were people of no faith, there were all kinds of different people that came to have these conversations about what was happening in mental health services and not, and importantly, what we could do about it. So there are barriers, but sometimes those barriers can also, that uniqueness of the identity can mean that those barriers, or what seem like barriers, can actually become opportunities, because through the things that I've lived, things that I know, that enable me to have a different perspective and to think about how you'd engage around research very differently with the people who are going to be the end users, whether that's the service users, their families, or the clinicians. And so I think, taking a positive spin on being an outsider, being different, saying things that nobody else is saying, wanting to do things that nobody else is doing, that can be the thing that unlocks the system. So I think, I'm not sure if that's answered your question.
It sounds from what you're saying that your background and your identity has actually not been so much of a barrier, but more of a thing that has helped and supported you in quite a wide range of ways from the sound.
It's not a barrier for me, but I think it can be for other people. So it's interesting that now there are lots of people doing research with faith communities. That wasn't always the case. To the point now where people talk about voluntary sector and faith communities and social enterprise. So it's become a thing. And so being a part of one of those people at the vanguard that turned that into a thing is great. I'm not saying it has to be acknowledged, but the fact that, we started doing that work when people were just saying, what are you doing? And I used to not be able to tell people at university what I was doing, because it was always in my weekends and in the evenings I'd planned stuff, because it was seen as being not research. It's not beneficial. Your research is about getting the grants, writing the papers. But in order to get the grants to do the kind of work that we need to do, we need to find out what people need. We need to find out what the barriers to them receiving the care that they need are. And the only way that you can do that is to have conversations with those people, not just the service users and their families, but the practitioners. What is it for you as a white clinical psychologist that might make it difficult for you to work with a Black man with psychosis? Have you ever considered what happens in the dynamic when you're in the room? Or is that because you're training, to what extent has your training prepared you to do that? Do you see what I mean? So if you don't have those conversations, how then do you open up a space where we can go, actually, what we need to do is to create a different form of intervention in which we acknowledge things like power differential and historical and contemporary legacies of inequity. So,
this moves us on really nicely, actually, to the next question that I had, which is about one of your innovations, the culturally adapted family intervention. Can you tell us about this and why you thought it was needed?
So going back to what we were just saying, this is not something that necessarily I thought was needed, but it's in these conversations where people said, as a service user, when I'm admitted into an inpatient unit, all I ever get is medication. There's never an option to have anything else. So not surprisingly, I end up with this kind of revolving door. So I'm unwell, I go in, I have the medication, I come out, eventually I become unwell again and I go in, but nobody is helping me and my family understand what's going on and how they can better support me, because that's just not happening. And although there are some cultural taboos about talking your business that we might need to overcome, we need an alternative. And we need, as people from a collectivist background, the I isn't the most important thing, it's the we. So approaches to psychological therapy, which are very individualized, don't really work for us. We need things that are going to work with, not just with our families, but actually our communities and our faith communities and people around us, because they're the people that are going to hold us and help us to remain well. So if you're really serious about recovery and have people remaining well, and then you need to think about the ecosystem that supports wellness, rather than treating people as an individual with 6 sessions of CBT or whatever else, because that's just not going to do it. And that's why we end up voting with our feet when that's all we're being offered, if it ever got offered anything at all. So out of that came these conversations, and that's where understanding that there were things already called different family intervention, family therapy, different approaches, and then working with people with lived experience as service users, carers, clinicians, about what do we need to change from the existing models to make them something that's more culturally relevant. So that's how it began in church.
It's amazing. I'm interested as well, more broadly, in some of your thoughts around clinical academia and your reflections. What are some of the things that you think clinicians get wrong when they think about a career in research?
I'm not sure that it's to get it wrong, because I don't know what getting it right is, really, because I've really kind of stumbled along a journey and been very blessed that I've had people who've shone a bit of a torch ahead of me to help guide me along. So I don't know there's necessarily a right or a wrong way. I think if there's anything we get wrong, it's just not even knowing it's a possibility. But that's not getting it wrong. That's just lack of awareness. And that's because no one's telling us that that's something that we can do. So I don't know whether it's that the curricula need to change to help people to understand, even a pre-qualifying, that having careers in research is a possibility, that you can be a clinical academic, that you can segue from your professional background and do something completely different. But certainly nobody told me that as a student or as an early career physio. I knew people did research, as I said, but I didn't think it was possible for me to do it. So maybe that's the issue, that maybe it's not the individual so much as a system that's got it wrong, where we're not enabling people. And I think the other thing is, if we're being very honest, with the amount of work that people have to do, where do you find the headspace and the space to think and the space to foster collaborations in multidisciplinary collaborations, which are the ideal, when you've got a massive caseload and you're being told that research is a bit of a luxury that you can't afford? You can't have time to do that, because who's going to do your work? So I think it's more of a system thing than an individual thing. I think once the system is more attuned, then the individuals who want to do it will come forward.
What does your day-to-day actually look like now? I'm wondering if there might be some clinicians listening who are thinking, maybe I can do this, maybe this is for me, but what is it? How does your sort of working week look like now?
Well, I should say it looks very different along your career trajectory. So as a lecturer, lots of teaching, certainly for me, writing the research grants and hoping you get successful and learning how to be resilient when you get the rejections. And then as you progress into more senior roles, then being expected to do more what we call service and leadership. So thinking more about how your research can actually change policy and practice, and leadership within your own field, within higher education, and so on. So it's not any one thing, and it changes as you progress. What it is for me now is research. Don't do as much teaching anymore, and not in front of a classroom, apart from more guest lectures. But it's much more teaching, as in supervising PhDs, clinical psychology doctorates, other research, to enable people and to support people to do research that I was being told was not possible. And it's one of the most gratifying things is over the recent, 10 years maybe, and certainly in the last 5, certainly since the pandemic, the number of people who have reached out from other institutions who've said, I'm a clinical psychology lecturer in this institution, and I have a Black trainee who wants to do research around Black women's mental health, and we don't have anybody here who can support them. Would you be willing to do that, to co-supervise? That wouldn't have happened before. What would have happened is that the trainee would have been, I don't know, subtly or maybe not so subtly, told to do something else because we don't have the skills in-house to do that. They wouldn't have necessarily thought about going outside. So I think things are changing slowly. But what would be great is if the people who are delivering the training or supervising the trainees had a mechanism for getting some of that insider knowledge themselves, doing the work that would enable them to supervise. And yeah, absolutely, like when I was doing my PhD, having somebody who was a psychiatrist who worked in the mother and baby unit as an advisor. So it's not about you knowing it all, but being sufficiently culturally competent, culturally confident, and culturally humble to know what you can and can't do, and be able to get the help and support to do it. And then what you're then doing is modeling that for your trainees, who I think it's still quite shocking. It's not just about clinical psychology doctoral students. It's across the piece that we're still training people. They're exiting their training to work in a multicultural society, and very few of them have ever done any work that looks at their own identity and how that shows up in practice, how that influences how they engage with people. They're in their own biases and what they know and don't know about people. I think that is appalling. That is... and that just reinforces the inequities because people don't know what they don't know.
No, absolutely. There are a range of initiatives happening to get more clinicians researching. Why do you think it's important that more physiotherapists in particular get into research?
So as a physio, I knew about evidence-based practice. I worked for quite a while in cardiothoracics and then in neurology. So I was really familiar with there being an evidence base, but not so much about what physios could contribute to that. And I do know quite a lot of physios who are research active. So I think it's about telling people. It's not even telling them, because even the ones who know it, it's about giving space to be able to develop the ideas. And I think, going back to what I said before about the systems, our colleagues who are medics have specific sessions that are set aside for them to do research. They're expected to do research, but we don't do that as physios. We have to do it on top of everything else. So if people who are in charge of the system really want more physios to do research, then we should create more of a level playing field. And I think that's the same across allied health professions, nursing, midwifery, social work, and all the others, that there is that disparity between medics for whom they're essentially in training, aren't they, until they become consultants. So they're expected to do research along their journey, but not for the other healthcare professionals, health and social care professionals. And that, to me, doesn't really make any sense. I know it's a bit like a broken record, but it does feel like it needs to be a different approach at a systems level that says all the people that are delivering care ought to be able, if they're not going to be research active themselves, They need to know how to facilitate research, because that is a major thing, recruiting people into trials when you need people to on the shop floor to consent them and they are just too busy. From that side, then all the way through, how do you interpret that evidence? How do I use that in my everyday practice? And how do I identify the gaps between what I'm reading and what I can see? Where are the gaps in the research that need to be filled? And the people who are doing it every day have got great ideas. What they don't necessarily know is how to move them from an idea into a research project that is fundable, and then how you get that from there to be NICE recommended, or as part of policy, or so many people can commission it. It's a long journey, and we don't know how the steps.
Fantastic. Thank you so much, Dawn. We are coming towards the end of our time now, and so I have my last question for today. If you could go back and speak to yourself at the very start of your career, what would you say?
Wow. The sky's the limit. There aren't any barriers. I would certainly never have thought as a student physio, or even as quite a senior physio, that I would end up doing research, and certainly not research into mental health. And so I think the key message I'd want to leave for everybody is that being an outsider and having an outside perspective is a superpower. Thinking outside the box is a superpower, but it comes with some challenges where sometimes you're going to get a lot of knocks. There's going to be a lot of pushback, and people who want to keep you in your box, keep you in your silo, tell you to stay in your lane, and will focus on all the things that you can't do and not understand the things that you can. So you have to learn how to do that. And you learn, certainly for me, learning how to do that is by being around really positive people who see the worth and the value in what I do and in me.
Well, thank you so much. Those are some wise words to end us on. So Professor Dawn Edge, thank you so much for sharing your story so openly. And I know that there's so much in here that's going to resonate with people that are listening. Dawn will also be joining us in another Manchester Catalys podcast episode discussing the barriers to research alongside our brilliant early career researcher, Laura McGarrigle. This is going to delve into the challenges that clinicians can face when moving into a research career, and it's focused on that early career stage. And it will provide suggestions as well to managing these, and some positive tips and encouragement for the journey as well. And if you're listening and thinking about your own journey into research, we hope this conversation has shown you that there's no single path, no one way, and that your perspective, your experiences, and your voice are important in research. Thanks for listening to Humans of Clinical Academia, and we'll see you in a future episode.